क्योंकि
सर जी सर।
एक्चुअली क्या है, हम लोगों का तो ये कॉलेज डिस्ट्रिक्ट सीतापुर में आ जाता है।
अच्छा,
एंड
सीतापुर वाला है सर ये। अच्छा अच्छा, हाँ
आप
हाँ
वहाँ
हाँ।
से जो कंट्रोल रूम से
हाँ,
ज्वाइन।
आपसे काफी बात हुई सर जी।
हाँ, तो
आपके यहाँ कम थे पेशेंट शायद सर।
हमारे यहाँ तो कम रहे, लेकिन सेकेंड
हाँ
वेव में अच्छे रहे, पेशेंट काफ़ी थे यहाँ पे।
हाँ।
लेकिन फर्स्ट वेव में सम हाउ हमारे यहाँ बहुत ही लो उसमें रहा पेशेंट्स रहे। लेकिन सेकेंड वेव ने तो तबाही मचाई डॉक्टर साहब।
हाँ सर।
आंधी और तूफान की तरह से आई और अपने साथ पता नहीं कितनों को बहा के ले गई।
हाँ सर, ये बात सही है।
जब रेट्रोस्पेक्टिवली अभी हम देखते हैं तो ऐसा लगता है, इवन माई ब्रदर, माई एल्डर ब्रदर, he is a retired professor of Aligarh Medical College. He was in ophthalmology department, and he could not get bed in times
हाँ।
of crisis when his oxygen level was falling down.
हम्म।
So I asked him to all the way come from Aligarh to this college, my own hospital here, Hind,
हम्म।
and I got him admitted here. And that time his oxygen level was around 78 or 80%.
ओ।
And he has been dean faculty of medicine
ओ।
of Jawaharlal Nehru Medical College. So, but here he survived. So everybody has faced this crisis. If you ask, discuss with, everybody has some story to tell. So that's the time of grave crisis. शुरू करेंगे. अभी यूनिवर्सिटी से भी कभी ज्वाइन नहीं किया.
पीना है ना, तो कॉपी कर लेते हैं ना.
पंखा ठीक है, इसको बाहर मना कर दो.
गुड मॉर्निंग मैडम.
हेलो मैम, गुड मॉर्निंग.
Good
वेरी
morning.
गुड मॉर्निंग मैम. नमस्कार.
तो
Can you hear me?
यस यस.
Yes ma'am. Yes ma'am, you are audible.
Okay, okay.
good morning, ma'am. Professor Indira Sharma from DHU. We are waiting for you. Myself, Dr. Kidwai, Principal Hind Institute of Medical Sciences. I think everybody has joined now. So formally we should start. So all of you are welcome in today's Google Meet for faculty approval. And we have only 3 candidates. Madam, I am audible to you. Professor Indira, I am audible to you.
Yes.
Okay. So everybody has
Be a
joined.
little louder, please.
Okay. So, madam, should we start now? There's only
Yes,
3
sure,
candidates,
sure,
one for
sure.
professor, one for associate professor, and one assistant professor. Dr. Nishchal. So everybody, okay.
Yes.
Yes. So Professor J.S. Srivastav, he is coming to you. डॉक्टर साहब अपने आप को इंट्रोड्यूस कराएं, थोड़ा जोर से बोलिएगा.
Hello everyone.
हेलो.
I'm Dr. J.S. Srivastav. I graduated from KG Medical University here, and then I did my MD in psychiatry. And presently I am working here as professor in Department of Psychiatry
Hind Institute of Medical Sciences.
वहाँ की आवाज सॉफ्ट है, उसको लाउड कर दो, वो दे दो ये ना, सुनाई नहीं पड़ रहा ठीक से.
Can you listen? Can you hear?
Yes, yes.
You can hear, Sanjay?
Yeah, I can hear, but be little loud.
Okay.
Okay.
Can you hear now?
Yes, yes.
I am working here as professor in Department of Psychiatry, and I am working in this institution for last 6 years, 7 years. So, if you want to know any other question related to me, you can ask me. So, I did my MBBS from KGMC, then I did my MD in psychiatry from KGMC. Can you? Yeah, they can hear. So, and then I have worked in the area of clinical trials for a very long time. And my total experience has spanned nearly 29 to 30 years, and I worked in KGMC along with CDRI in collaboration with CDRI. So my total experience has extended nearly 29 years there for in clinical trials. And then I have joined here as earlier I was in Hind Institute of Medical Sciences in Safedabad for nearly 3 years as associate professor, and then I joined here in Hind Institute of Medical Sciences in Ataria as a professor designate in 2018, and I remained as professor designate for 3 years, and then I have joined as professor recently for last 4 months. You want to know any further?
I would like to know from you.
Yeah.
You have tremendous experience of research. So,
Yes.
what were the areas of your research?
My main area was clinical trials.
On
I-
which?
on antidepressant and antipsychotic. One antidepressant which was developed by CDI was Senbutindol. I think probably you may have heard about it. Senbutindol, and then antidepressant. This was Centroprazine, and this phase 1, phase 2, phase 3, all these 3 stages I have worked in cent- Centroprazine, and finally it was approved for marketing, and it was taken up by a company also, pharma company, but unfortunately it could not see the market light. It was not in the market. It could not come to the market. So that was one, and then I also participated in Memory Plus trial. I think you heard about Memory Plus. This Bacopa, it was developed from Brahmi plant, and this is Bacopa moniera, and then it was marketed as Memory Plus. So that is, and still I am in touch with CDRI, and we are coordinating with their clinical trial. They are working on corona vaccine also. So I'm there in ethics committee in CDRI ethics committee. So I am still continuing with them.
So, it is nice to see that you have done this research.
Yes.
What I would like to ask you, that we have so many antidepressants available in the market.
Yes.
How do you integrate that information? Why do we have so many antidepressants?
Antidepressants, many antidepressants are there because of the side effect profile. It has to be preferred according to the side effect profile, which one we want to give to the patient, and depends upon the, because the earlier side effect, the antidepressant, the tricyclic antidepressants which were there, the anticholinergic side effects were more, and now the SSRIs which have come, the side effects are much less as compared to tricyclic antidepressants, and they are doing much better. So the preference is much more for the SSRIs, although the some SSRI and SNRI combined are also available there. So the
So
preference
you
is
are
for the SSRI.
You have rightly pointed out the problem with the side effects,
Yeah.
but how about the etiology? Has it any implications for etiology? Can we say that the depressive illness that we see has got multiple etiologies?
Yeah, it has multiple etiologies. I think some depression may have serotonergic origin, some may have noradrenergic origin. So the less serotonin available. So we have SSRIs. Then we have there is combination, but you cannot say that on the basis of the clinical profile what the patient is suffering from. The etiology cannot be as such assessed on the basis of the clinical profile. So we have to give the antidepressant and then see the difference depending upon the severity of the depression. If the patient is very severely depressed, then we still we try the tricyclic antidepressant, and the mild to moderate depression usually very easily responds to the SSRIs, especially the escitalopram and the recently some newer antidepressants have also come. So I think, is anything more you want to know?
Now, I just want to ask you one question.
Yeah,
With the advent of different antidepressants, which are very effective,
right.
there is a tendency for the postgraduates
Hmm.
to, when the patient says, I'm depressed, they write the antidepressant without going into the psychosocial causes which may have contributed to the depression. So, how do you integrate this biological and the psychosocial information that is available for the treatment of the patient? What is
Yeah,
your comment?
if we have psychosocial factors also, then we have to integrate with the psychotherapy. The counseling has also to be integrated with the patient, and then the combination of these two, the pharmacotherapy as well as the counseling, has to be done. Cognitive behavior therapy, and depending upon the situation, how the patient is, what type of problem the psychosocial nature is, then according to that we have to manage.
Now, another question that I would like to ask you, when you are talking of pharmacotherapy,
Right,
the Mental Health Act,
right.
and we also know that there are some therapies which are very effective, but patient may not be willing to take them. So, what is your proposal for giving patients covert medication
If
without
patient,
their consent? Without their consent, what is your what do you have to say about it?
if the patient is not willing to take the patient, I think we should not be forcing the patient to take the medication. We have to be, because involuntary treatment is not permissible as per the Mental Health Care Act. So we have to discuss with the counsel with the patient that the medication is required just for the relief, and we will help the patient out with the counseling and the psychotherapy.
Involuntary treatment is for involuntary treatment, one has to admit the patient, and
Yeah,
there's certain procedure that has to be adopted.
yeah.
But the Mental Health Act, does it say anything about outpatient involuntary treatment?
But I think involuntary treatment will not be, I think, justifiable. I think as ethicist, I would not like to force the patient to uh, just counseling the patient to, if the patient gets willing, we may have to have some sessions, and then the patient agrees for the pharmacotherapy. That is what happens. That is what I have seen.
So you are right. I think this is a very difficult area to handle,
Yes, I
where
think
we
so.
know that if the patient takes, he will improve, but he refuses to take. So what to
Yeah.
do with these patients? So I
Yes.
think we need some guidelines on this so that we don't get into trouble.
Right.
Now, the
Right.
last question I would like to ask you,
Yeah.
since you are now aspiring for the professor's job, you will be leading the department.
Yeah.
So, what are your plans? What are areas you would like to focus as
Yeah.
far
So
as your work is concerned?
yeah, I think I'll go because I'm working in a rural setting. This medical college set in the rural area. So I think I would like to study the psychopathology as per the area here, how the depression is presenting, how the schizophrenia is presenting, and how the OCD is presenting, and what problems and what are the how we can convince the and deal with the stigma and all those things. Still, in this area, I have seen that a lot of people have superstition and they come with the problem of that ये झाड़ फूंक से ठीक हो जाएगा and all these things. These things have to be dealt with in this particular setting. So that is one very important area I would like to research. And then
So, in the same line, I would like to ask you, what is your comment about home based rehabilitation? Because now you find that there's a proliferation of rehab centers. So, do you recommend your patients to get admitted in these rehab centers, or you would like to recommend home based rehabilitation?
I think these rehab centers who admit the patients, they are not doing as well as I am. I'm not very happy with the situation there. So home based rehabilitation and the daycare center, what we are planning to have in our institution. So I think that should help much better than the patient. And if we want to admit, we can admit the patient here. We have 30 bedded unit here. So we can admit here, and then we have an occupational therapy room here, and we will try to, rather than sending those patients to the rehab centers, we will like to deal with them uh, with our own methodology, I think, with which we will develop in our institution. That is,
Oh,
I think, my.
okay. Thank you very much.
Oh, thank you.
That's all.
So, ma'am, and all the members, do you approve him for the post of professor?
Yes.
Okay,
Yes.
thank you very much.
Yes,
So
sure.
we'll call the next candidate.
Yes.
सर आई वुड लाइक टू आस्क वन थिंग, जो एनएमसी क्राइटेरिया है वो तो आप लोगों ने चेक कर लिया होगा ना, मतलब
जी।
डू वी नीड टू गो इनटू दैट?
बिल्कुल हम लोगों ने चेक किया है और अभी लास्ट मंथ हमारा एनएमसी इंस्पेक्शन हुआ था फॉर
जी
पीजी
जी
सीट, तो एनएमसी
जी,
इंस्पेक्टर हैज ऑलरेडी अप्रूव्ड हिम.
ओके राइट. सो फॉर
हेलो
ऑल द थ्री
हेलो
कैंडिडेट्स,
सर, गुड मॉर्निंग.
वेरी गुड मॉर्निंग मैडम, वेरी गुड
सर
मॉर्निंग.
गुड मॉर्निंग. मैं ये कहती सर, ये फैकल्टी अप्रूवल बेसिकली हम लोग एमसीआई का जो नॉर्म्स है उस हिसाब से रख लेते हैं. फैकल्टी इंस्पेक्शन भी कराया इन सभी फैकल्टी ने. ये
जी
जस्ट
मैम,
फॉर एग्जामिनर बनने के लिए, इंटरनल एग्जामिनर बनने के लिए हम लोग को फैकल्टी अप्रूवल फ्रॉम यूनिवर्सिटी लेना पड़ता है. तो दैट इज ओनली
राइट,
फॉर
ठीक,
एग्जामिनर.
राइट राइट, परफेक्ट मैम, आई अंडरस्टैंड. तो फिर अब ठीक है, फिर दैट इज क्लियर कि वो सब चेक्ड है. तो देन
यस सर.
आई थिंक मैडम ने पूछ ही लिया है सब काफी सारे क्वेश्चन, सो आई आल्सो
हाँ
अप्रूव.
हाँ जी जी जी, थैंक यू सर, थैंक यू वेरी मच. वैसे बेसिकली सर ये लोग सब एज पर नॉर्म्स पूरे कंप्लीट है, बस जस्ट बिकॉज ऑफ अभी हमने पीजी का इंस्पेक्शन कराया है, तो पीजी के बच्चों के लिए जो एग्जामिनर इनको बनना है वो भी आज नहीं, अगले 3 साल बाद. तो उसके लिए इनको फैकल्टी अप्रूवल लेना पड़ता है, तो वो फॉर्मेलिटी है सर.
हाँ बस ठीक है
थैंक
मैम.
यू
सो
सर,
दैट
थैंक यू
आई
वेरी
जस्ट
मच.
वांटेड टू कंफर्म दैट.
थैंक यू सर, थैंक यू वेरी मच.
So,
नेक्स्ट डॉक्टर अभिषेक पाठक.
डॉक्टर अभिषेक आइए.
ही इज एसोसिएट प्रोफेसर मैडम, ये एसोसिएट प्रोफेसर हैं, और बाकी अपना डिटेल्स आपको अभी बताएंगे.
A very good morning to all the respected and esteemed expert faculty members. I am Dr. Abhishek Pathak, and I did my MBBS from Sikkim Manipal.
डॉक्टर अभिषेक, यू मे स्विच ऑन द कैमरा प्लीज.
सर उनका कैमरा ऑन है सर, आपका कैमरा ऑफ हो गया है. डॉक्टर निश्चल आपका हाँ, अभी अभी आपका ऑफ हो गया, ऑन हो गया सर.
मेरा कैमरा ऑन, मैंने तो ऑफ किया था, पर इनका मुझे नहीं दिख रहा है, तो हो सकता है मेरा नेटवर्क
नहीं, इनका ऑन है, इनका ऑन है सर, इनका तो हम लोग को दिख रहा है, मुझे भी दिख रहा है.
अच्छा राइट राइट, ठीक है ठीक है, ओके देन देयर इज सम प्रॉब्लम फ्रॉम माय साइड. चल प्लीज कंटिन्यू डॉक्टर अभिषेक.
I did my MBBS from Sikkim Manipal Institute of Medical Sciences in 2007, and I did my MD Psychiatry from IMS BHU Varanasi in 2012. Subsequently, I went and completed my senior residency from NIMHANS, Bangalore. And then I have also done 1 year of assistant professorship at Uttar Pradesh University of Medical Sciences, SFI. I have also worked as assistant professor at Hind Institute of Medical Sciences, Safedabad, and for past 4.5 years, I am working as assistant. I am working as associate professor here at Hind Institute of Medical Sciences, Ataria, Sitapur. I was promoted to the post of associate professor in the year of 2020, 24th February 2020. So since 24th February 2020, I have been working as associate professor in Department of Psychiatry, IMS Ataria.
So, Dr. Abhishek, can you let us know about the main areas in which you have worked?
Ma'am, while I was in BHU, I have worked in area of marriage and mental illness. Then in NIMHANS, I was working in the unit of Department of Psychiatric and Neurological Rehabilitation under Professor S.A. Chaturvedi sir. So mainly I have worked in these areas.
You also received an award, I remember,
Yes,
when
ma'am,
you
that
were in
was.
BHU.
Yes, ma'am. That was for the best paper award for my thesis.
Thesis work,
Yes,
yes. What was the
psychiatric.
topic?
Ma'am, psychiatric morbidities in patients of essential hypertension. It was in the conference organized by World Hypertension League and Indian Society of Hypertension at Annamalai Nagar, Tamil Nadu.
So, what is the main implication of that study?
Ma'am, it shows that psychiatric morbidities are associated with hypertension and mainly uh, increased severity of psychiatric morbidity was present in stage 2 hypertension. Actually, we graded the hypertension according to JNC 7 criteria. So, in the study, we found out that psychiatric morbidities where there was more prevalence of depressive disorders and anxiety disorders in patients of essential hypertension presenting to cardiology OPD, and especially if patient had grade 2 hypertension, then patient had more severe psychiatric morbidities.
What about major depression?
Yes, ma'am, it was present in about 47% of the patients of primary hypertension.
So, what implications does this have?
Ma'am, this shows that we should be cautious while dealing with patients of hypertension because sometimes antihypertensive drugs are also known to cause depression. Similarly, if psychiatric morbidities are not controlled effectively, then there is poor compliance to antihypertensive medications, and it can also have an adverse impact on blood pressure. Blood pressure can increase drastically. And even some antidepressants are also known to increase the blood pressure. So we have to look also about the interaction between various drugs while prescribing antihypertensive and antidepressants in such patients.
Okay, are you aware of the problems that psychiatrists all over the country are facing with the Mental Health Act?
Yes, ma'am.
Can you
Ma'am,
highlight some of the problems?
Ma'am, the main problem is for example, ma'am, advanced directive and nominated representative. Currently, in the new Mental Health Act 2017, there is provision of advanced directive that every person who is of above 18 years of age and of sound mind can sign an advanced directive and can nominate a representative, and they can declare how they wish to be treated during acute exacerbation of psychiatric illness, whether they wants to be admitted or not. So sometimes, like in cases of medical emergencies, it becomes very difficult to arrange for advanced directive. Sometimes there is we need to give emergency ECT in cases of catatonia, which is a life-saving procedure, or if patient is having severe depression with suicidal ideations, we need to give immediate ECT. But like if a patient has written in advance directive that he or she does not want to receive ECT, then psychiatrists are helpless. Then secondly, in case of nominated representatives, sometimes if patients have included their family members under the rubric of their delusions, then uh, they appoint some other nominated representative other than their family members. So they might be exploited by those nominated representatives. And thirdly, because of these central mental health authority, state mental health authority, and then there is district review board, mental district review board, it has become more of bureaucratic and judicial rather than therapeutic. There are lots of red tapeism involved. Even if we want to extend the admission of a patient beyond 30 days, then we have to like approach the district mental health review board. So there are lots of difficulties involved.
Any other problems?
Uh, Ma'am, they have banned unmodified ECT. Earlier, unmodified ECT was also given in cases of emergency. Sometimes in rural areas or far-flung areas where availability of anesthetics is not there, then people cannot give modified ECT. So they have to resort to unmodified ECT.
So that what you have said is correct, that anesthetics may not be available.
Yes,
But the other point, has it been highlighted that in some patient direct may be safer than modified?
ma'am, like in direct has more adverse events. Direct ECT is associated with more adverse event as compared to modified ECT. But sometimes, like in cases of unavailability of anesthetist, or if there is an acute emergency, sir, ma'am, then we might have to give unmodified ECT.
In the you must have given ECT to so many patients, and I think all of us
Yes,
who
sir.
have been trained have been giving ECT. But the usual method is to give a benzodiazepine, not anesthesia, with atropine, and then give the ECT. So do you think this is okay?
Ma'am,
Because we have a
benzodiazepine
position
is,
statement on ECT.
yes,
Because
ma'am.
this is another area where some of in the west zone they have highlighted that in many cases the direct ECT may be safer.
Yes, ma'am.
This is just I want to let you know. Because once you give a modified ECT, patient is subjected to double risk, the ECT plus the anesthesia. When you give him direct, he only gets the risk of ECT. So in some cases, this is safer. So maybe you can look at some of these references.
Yes,
Now, you have just mentioned that you have done some work on marriage and mental illness. So I
yes,
would
ma'am.
like to know your comments with regard to the marriage laws. Are they okay? Especially the
No,
Hindu
ma'am.
Marriage Act.
Ma'am, Hindu Marriage Act was framed in 1955. That time, drugs like chlorpromazine just came, but they were not available in India. ECT services were not available in India, so effective psychiatric treatments were not available. And in under Section 12, they have mentioned that marriage can be held null and void if either of the party is not capable of giving consent. But in Hindu marriages, generally consent is of proxy nature. It is generally given by their guardians. And secondly, it is written that if they are suffering from any if they are capable of giving consent, but if they are suffering from any mental disorder of any kind, or up to such an extent that they are not able to fulfill the all the necessary obligations of a marriage, or if they are not fit for procreation. But there are far more debilitating physical diseases which can be responsible, which can hampers a person's ability to carry out or fulfill all the obligations of a marriage. But why held mental illness is responsible alone in such cases? Whereas mental illnesses, the course of mental illness changes over a period of time, except if we are talking about acute exacerbation of symptoms in schizophrenia. that time a patient might not be possible. It might not be possible for patient to carry out the essential obligations of marriage. But rest of the time, if patient is asymptomatic, patient is very well able to give consent, and patient is able to carry out all the essential obligations of marriage. So why this discrimination against mental illnesses? And then thirdly, they have also mentioned that should not suffer from recurrent attacks of insanity, which is a very derogatory term. Earlier there was this term included recurrent attacks of insanity and epilepsy. In there was an amendment in 1999 where they removed this word epilepsy, but recurrent attacks of insanity has still been included. So this should also be removed. And then mental disorder is a very general term. It can also include mild disorders like dysthymia, mild anxiety disorders, mild depressive disorders. It can range from these mild disorders to severe disorders like schizophrenia, bipolar. So they have included all the disorders under one rubric. So if a patient is undergoing treatment for example, say mild depression, their in-laws can say that this person is suffering from mental illness, and then they can file a petition in the court for annulment of marriage. So this is a major problem.
So do you think some amendments are required?
Yes, ma'am. Some amendment should be done first. This word insanity should be removed, and why this discrimination? Uh, they have, in fact, I think this is a like casteist discrimination. They have also discriminated against mental illnesses. Physical illnesses are of higher class, and mental illnesses are of lower class. So they have discriminated against mental illnesses. While nowadays, with recent advancement in psychiatry, like 70 to 80% of psychiatric illnesses can be treated with effective treatment, but still, uh, hold. I think a person's it is a basic right of person to get married, but preventing a person from getting married because of mental illness is discriminatory. Then secondary, there
You
is
have,
also
you, you
provision
have
that
rightly pointed out that right to marriage is should be there for all patients. It's a human right declared by the United Nations. So I think this is what the Hindu Marriage Act and the Special Marriage Act ignore. So I think there is a definitely a need for amendment. Okay, so having said all this, I just want to ask you, what are the areas in which you would like to focus in future?
I would like to work on de-addiction.
What type
And
of de-addiction?
mainly alcohol and opioid. And I have also worked in psychiatric rehabilitation at Nimhan, so I would like to work in that area also. Because nowadays, generally, we only talk about symptom-based recovery, but we don't look at the person as a whole, as a human being. So I would like to work on recovery-oriented services. We'll try to reintegrate the person into the community itself.
Okay, thank you very much.
Thank you, ma'am.
Thanks.
So,
Thank
okay,
you.
thank you. So, do you approve him for the
Yes,
post?
we approve him.
Okay, thank you.
Thank you.
We call the next candidate.
Sure.
Now, Dr. Saurabh
Hello.
Jaiswal.
हेलो
Yes,
हेलो मैं हेलो
yes.
Yes, madam, you are audible. आप बताएं.
मैं ये बोलती हूँ मैडम, थैंक्स फॉर अप्रूविंग हिम. डॉक्टर अभिषेक वाज वेरी, बहुत ज़्यादा आपसे डर रहे थे वो. आप उनके टीचर भी रह चुकी हैं, इसलिए मैंने कहा जस्ट आपको बता दूं कि ही वाज वेरी अफ्रेड ऑफ यू. वो बोले थे कि नहीं वो हमारी टीचर है, पता नहीं क्या करेंगी, मेरे को बहुत डर लग रहा है उनसे. मैंने कहा नहीं आप चिंता नहीं करो, आने दो, फिर देखते हैं, मैडम से बात करेंगे. आपने अप्रूव कर दिया, उसके लिए थैंक यू वेरी मच. डॉक्टर अभिषेक कहाँ हैं आप?
अभिषेक आइए, सामने आइए.
I was a very strict teacher.
या
Okay.
आपका डर खत्म हो गया ना डॉक्टर साहब अभी?
नहीं मैं सब कुछ मैडम से ही सीखा है साइकेट्री
नाउ
पूरी
नाउ
मैडम
यू आर टीचर, नाउ यू आर पीजी टीचर, आपने मैडम से सीखा है, तो इसलिए मैंने कहा आप डरना बंद कर दीजिए, आप बहुत डर रहे थे आप मैडम से, लेकिन मैडम ने देखिए आपको बहुत अच्छे से सिखाया भी और अप्रूव भी कर दिया। आई एम वेरी थैंकफुल, थैंक यू वेरी मच मैम, थैंक्स अ लॉट।
So thanks, Dr. Saurabh Jaiswal. He is assistant professor. आप अपना इंट्रोडक्शन दीजिए।
Good afternoon, respected teachers. My name is Dr. Saurabh Jaiswal. I have done MBBS from People's Medical College, Bhopal, and in 2011, and I have done my MD in Psychiatry from Royal Medical College, Bareilly. After that, I have done senior residency in the Central Institute of Psychiatry, Ranchi. Thereafter, I came to Lucknow and I have joined in Hind Institute of Medical Sciences as a senior resident, and then I was promoted to assistant professor on 1st of February 2019. So currently, I am working as a postdoc assistant professor in Hind Institute of Medical Sciences.
What was your thesis topic?
Ma'am, my thesis topic was psychiatric comorbidity in patients with epilepsy.
So how do you distinguish? Suppose the patient with epilepsy comes with psychiatric symptoms. How will you make a final diagnosis, whether it is schizophrenia or whether it is epilepsy? What is the main yardstick?
Making a diagnosis of epilepsy is mostly clinical, which is backed up by the investigation, which includes neuroimaging, blood investigation, and all the routine investigations. But mostly it is backed up. Mostly it is made by the clinician. So the criteria of making the epilepsy, either it is partial or generalized, or whatever the epilepsy is made clinically. And the topic of my research was to look for episodes of to look for psychiatric comorbidity during interictal periods of epilepsy. So when the patient is not having the ictal period, in those periods is he comorbidly suffering from any psychiatric illness?
So what comorbidity did you get?
Ma'am, in my research work, I found that depression was most common, followed by anxiety disorders. The depressive disorders were found to be about 20 to 21% of patients suffering from epilepsy, and anxiety disorders were found to be around around 19 to 20% in patients suffering with epilepsy.
Okay, what are the areas in which you have worked?
I have worked in during my MD period. I have worked in the research areas of my thesis. After that, I have worked in Central Institute of Psychiatry. Mostly, there was a
No,
clinical
area. Give me the area, not the
adult.
place.
Yes, ma'am.
What areas of psychiatry that you have done work?
I'm adult psychiatry, and I was placed in adult psychiatry as well as de-addiction.
De-addiction.
Yes, ma'am.
Okay, can you tell us something about de-addiction to tobacco dependence, which is very common in our country?
Yes, ma'am. Tobacco dependency is one of the most common addiction which we face in our regular practice. First, we have to look for the motivation of the patient. Is he motivated? Has he come on his own, and is he motivated to go for the addiction for tobacco? Then we can look for if his motivation level is not appropriate, then we can go for the motivation enhancement therapies. And for the pharmacological part, we use bupropion as well as nicotine patches and lozenges and gums which the patient can use.
Are you in favor of replacement therapy? Is it ethical?
Uh,
Because this is something which is being practiced world over,
Yes.
replacement therapy. It
Yes.
is a paradox because
Yes.
on the on one hand you want to detoxify, on the other hand you are actually medically prescribing the same drug to the patient.
Yes, ma'am.
So do you think it is ethical to do so? I'm
Ma'am,
just asking you as a clinician.
yes, ma'am. According to me, there in clinical practice, there are many patients who find it very difficult to leave the tobacco because it's very normal for them to. It's a part of their routine and daily habit. So whenever they are free, they used to go outside and eat tobacco. So it becomes very difficult to motivate them and to make them come out of this habit because everyone around them is using the same habit. So getting the patient motivated becomes very difficult without using the replacement therapy for some time.
So you think it is okay? Anyhow, uh, I think this is a highly controversial, giving replacement therapy to addicts, and
Actually,
same thing is with methadone also. Uh, Anyhow, I think tobacco dependence is usually not difficult, and even if it is a habit, you can always find ways to overcome that habit. You have to be more intensive in your efforts. Now, having said this, I want to know your critical comments about the Mental Health Act.
Mental Health Act was made into an act in 2017, in which the ECT was banned for the minors. In any indication, the ECT was the direct ECT was banned, and only modified ECT was allowed in circumstances when the patient is needed, as well as the patient can give uh, direct advance directives and nominate his representative. So the
Is there any, what is your comment about mental health capacity?
mental health capacity, it becomes very controversial because at the time of giving the advance directive, it is very that the anyone cannot know what was the capacity at the time of writing the advance directive. So it may be possible that a patient who is writing an advance directive, he might be suffering from some delusional levels or some kind of psychiatric illness, and he might be giving advance directive under those influences. So ethically, it becomes very challenging to know when was advance directive was written and what was the mental capacity of the patient, whether he was whether he had the capacity to write the advance directive or not.
Not only
but
for
doctor,
that, even for
uh,
admission.
Yes, ma'am. For the admission, the patient can go for the voluntary admission, and he can, if the patient does not want voluntary admission, he can go for assisted admission, in which the family members have to sign, and he can be put in for a 30 days period. And if the patient is wandering on the road, he can be involuntary taken by the local police officers, and he can be put into the psychiatric hospital. And for after a period of 30 days, district mental health review board has to be formed, and his extension can be granted for a period of 90 days.
Okay, thank you very much.
Thank you, ma'am.
So, thank you very much. Is he approved for the post?
Yes, we can approve.
Okay. So he was the last candidate in front of you. Uh, Let me express my sincere thanks on behalf of the Hind Institute of Medical Sciences and for this interview and all experts of this panel today. So, should we wind up now?
Thank you, madam. Thank you, Thank you, Dr. Nishal sir, Dhananjay
thank
sir.
thank you.
Thanks a lot. आप लोगों ने अपने बिजी टाइम में से टाइम दिया. दैट्स वी आर वेरी ऑब्लाइज्ड. थैंक्स ए लॉट. और अगर आप लोग की कंसेंट हो तो हम लोग अभी एग्जामिनर के लिए भी आपको बुलाने की वो करेंगे. तो प्लीज